Hi, this is Meg. Welcome to Spit It Out. This is where we cut the fluff and spill life's real truths. In cue of the holiday season, I have a little treat for us today before I get into all the nitty gritty of diagnosing, co-diagnosing periodontal disease and gingivitis. I figured we could do something fun. I was at my local Walmart and I found pumpkin pie flavored cup noodles. Don't ask me who invented this, why it was invented, or if it tastes good, because I don't know yet. But I do have a kettle behind me and I am going to set it to 212. I think that's what Google told me to do. I'm going to heat up this water, and when it's done, we're going to try it out. I just realized I don't have a fork, so I'm not really sure how I'm going to eat it, but I might have to pause and go grab one really quick. I'll be right back. Okay, fork has been acquired. I want to take it back to dental hygiene school when we were first learning about staging, grading, all that fun stuff. I don't exactly remember learning much about dental codes, as in ADA codes that you submit to insurance, providing them with information as to what you did during the appointment. I remember learning about periodontal disease, what gingivitis is, how it happens, etc. But I always struggled with understanding how to properly diagnose in dental hygiene school because in my experience, the instructors didn't seem to fully agree on the wording on it and how to even properly diagnose in the first place. I don't know if anyone else has had that experience. If so, I'm sorry. I know it can be really hard being in dental hygiene school thinking, oh, I'm supposed to know how to do everything. And then you leave going, oh my gosh, I don't know anything. I really don't. Because it's tricky. The world in dental hygiene school teaches you that if there is a little bit of crestal bone loss in a 4mm pocket, you need to do scaling and root planing on them. In the real world, we are kind of groomed to abide by insurance's logic. And in the real world, if someone has a tiny bit of crestal bone loss, no subgingival calculus, and a 4mm pocket, they have gingivitis. As you can see, there are two different things going on. One of them is by the book, which is technically correct, Sure, you can consider some bone loss to be periodontal disease, but insurance kind of has a point because sometimes you get in situations where people do have crestal bone loss and a little bit of inflammation, but it's not due to traditional periodontal disease. It could be due to clenching, it could be due to orthodontics, it could be due to so many things going on that are outside the scope of needing scaling and root planing. That's where the gingivitis code D4346 can come in and at least try to see what's going on before going straight into gum disease territory, periodontitis territory, all that fun stuff. There's been a couple times where there's a patient with a little bit of bone loss, but I don't know exactly what it's caused from. I'm not really sure yet. Maybe it's the first time I've seen this patient. I will suggest let's do a D4346. I'm not really sure if the bone loss you have is due to periodontal disease because you have really great home care. You don't have a whole lot of blank, whatever. I'll kind of describe what I'm seeing to the patient. And let's just see if maybe you do just have some gingivitis and maybe you're clenching a little bit, or maybe you have a brief history of orthodontal or something like that. Let's just see what we can do first before jumping into periodontal disease. And there's been some cases where we will treat them as gingivitis and their pockets will get better, which is great. That's awesome. And then there are some times where we'll treat them like they have gingivitis because it looks like they might. And actually, on a second look, maybe 3 months later, because we have a little bit more time, we realize, oh, maybe this person does have periodontal disease. But the best part about that gingivitis code is that we can kind of lead them in the right direction on how to start taking care of their mouth, teeth, and gums. And so by the time, if they get diagnosed with periodontal disease, it's not a complete shock. They're kind of prepped during that first appointment. I do that with most of my gingivitis patients. I let them know that, hey, it looks like you do have some gingivitis. You have some suspicious areas, but I want to see if it is just gingivitis, because if it is, great. If you're doing everything I'm telling you to do at home, I treat you with this procedure code and everything looked great, awesome, we were right. But if next time you come in, we take new x-rays, take new probing depths, and things are still not looking great or looking worse, yeah, it might be time for the next step, which is scaling and root planing. I hope all of this makes sense. I'm just kind of going through my process and some of my colleagues' processes throughout the years to make sure we are treating the patient properly and not just jumping straight into periodontal disease, because a lot of the time, every patient has different underlying factors that determine what is going on in their mouth, if that makes sense. Moving forward, there was a time where I was working with a periodontal hygienist. She had just worked at a perio office for about a year, and then she went to my office, which was fantastic. I, for some reason, got into like a weird rut where I was not confident in any of my diagnosis. I was getting myself confused with clinical attachment loss, recession, bleeding, pocket depths. I don't know what was happening, but I just really needed a couple second opinions. And thankfully, she was there to be like, hey, I actually would do SRP in this quadrant as well as the other ones. Or I don't know if I would do that. It's not quite advanced enough. Let's just treat them like gingivitis and let's just see how that goes for a little bit. But she would also just help me feel better. I really just needed that pat on the back sometimes that hey, you know what you're doing. You are doing great. Don't stress out about it. Because I, as a new grad, was really struggling with my confidence. I struggled with getting out of hygiene school and being able to tell someone they had periodontal disease without freaking them out or sounding super scary. I've learned over the years that you do have to balance scary with being kind. And you always have to be kind. Don't let that get over your head. I always am kind, but you have to be firm and you have to tell the patient the science at the same time. And every patient is going to accept the news that they have periodontal disease different, or even that they have gingivitis. Some people kind of freak out over that too. And I feel like telling them the facts that, hey, gingivitis is reversible. We can prevent you from losing attachment loss, but we have to follow the steps of taking care of ourselves. Over the last 2.5 years, I've really been able to walk into any operatory and figure out the vibe within about 10 seconds. I think just introducing myself to a patient, walking them back into the room and chatting with them just about their chief concern can give me a pretty good understanding of where they're at, their level of maturity even, because when it comes to talking about serious health issues, you do have to trust your provider in a way. There's always room for second opinions, but you really do have to put your faith into your provider. And if you as a provider can come off as confident and strong-willed with your diagnosis and co-diagnosis with your dentist, it just makes the patient feel so much safer, especially if they struggle with dental anxiety or shame or neglect, anything like that. I got a lot of patients who tell me that they didn't want to come in because they felt ashamed. I tell most patients that, hey, we have this issue and we're going to treat it, but I'm just happy that you came in now. Because, if you would have waited maybe 10 years, this would have looked completely different. But you came in now and we're doing the hard work now so that your long-term health can be successful. And a lot of the times that can turn a very negative, scary situation into something a little more positive and uplifting. Okay, little break. Let's try this ramen. Let's try it. I think it's been enough time. So, oh yeah, I think she's ready. Oh my God. Ooh, I don't like that. It's like, I didn't even have another bite of that. That's actually horrible. That's actually horrible. And here's something I missed. It says, for an even more satisfying pumpkin pie experience, try topping with whipped cream after microwaving. No, I'm going to throw that in the trash. That was so exciting. I'm so glad that I tried that. Yeah, no. It's literally supposed to be like a dessert, but I think that one's a miss. I'm not a fan. Anyway, another thing that a lot of new grads will probably run into is that a lot of dentists won't trust your judgment. And a lot of dentists just want you to be a tooth cleaner or a little robot and just do whatever they say. I'm the type of hygienist who I need to work with a doctor that I can trust completely and that they can trust me completely. I am well aware that I cannot diagnose pretty much anything. In the state of Idaho where I work, there is a dental hygiene diagnosis that is written into my practice. It is not a dental diagnosis to where legally I can state that someone has something, right? But it is a little step above saying you might have this, right? So the whole point of a dental hygiene diagnosis is that I can bring this information that I have successfully gathered from probing, radiographs, whatever, bring it to the doctor. We work together and then they basically confirm the diagnosis or deny, that can happen too. But it is recognized in my state, which is great. I wish I had more capabilities beyond a dental hygiene diagnosis, but that's a podcast for another day, for sure. I've worked with some dentists that don't diagnose any perio and don't refer anything ever because they don't believe in it. I've worked with doctors at a temping spot where I said, hey, this person has periodontal disease in a 6mm pocket with bleeding on the upper left. They need to come back for SRP. What's your typical office procedure? And the dentist had his feet up on the desk and kind of like looks at me and is like, you can just do a debridement. And I went, no, the patient doesn't need a debridement. They need SRP. What do you want me to do? And so it just like created this contention because I'm like, dude, I'm literally telling you what I just want to know like what the next step is that you do at your office, whatever. Never went back to that office. It was a nice spot, but it was also like not left-handed friendly at all. So good riddance. Anyway, another thing that helped me with dental hygiene diagnosis when it comes to periodontal disease and gingivitis is just studying up on the ADA codes. It's pretty simple, in my opinion. I feel like if you just know the code through and through, you kind of have it memorized, or you could just pull it up really quick. It's really easy to kind of match them together. Dental hygiene code D4346 is literally scaling in the presence of severe gingivitis, full mouth. So if you think about it like that, what is considered full mouth? 30% of the mouth with bleeding, 4s, etc. Maybe some 5s, honestly, pseudo pockets. Yeah, I see that a lot too. Mark all of it down, do the math in your head, and if the shoe fits, honestly, I've had some cases too where I think it's a prophy, and then I get in there and bleeding everywhere. I must have just like not probed hard enough, or like maybe the vibrations kicked in the inflammation factors a little bit. And then I'll kind of like look at the patient and I go, hey, your case is a little more involved than I thought. You actually do have severe gingivitis and I'm going to help you with that. But I just have to let you know your insurance may kick back a little and give you a copay. There's a couple different types of cleanings we do. There's one for healthy mouths, which they like to cover. There's some for gingivitis where sometimes that's a hit or miss, and so on and so forth. I'll explain all of them sometimes. And it kind of gives them a picture of like, okay, that makes sense. Like, yeah, they only want to cover healthy mouth. I don't have a healthy mouth. I have gingivitis. That's a very basic breakdown. Every patient, I explain it a little differently, but the basic thing that I like to just emphasize with patients is that your insurance will only cover healthy mouth cleanings, a prevention of disease. You do not have a healthy mouth. We have gingivitis, which is inflammation of the gum tissues, or we have periodontitis, which is bone loss and attachment loss, blah, 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 whatever. So separating the two and literally even just like holding up your hand and going through all of them, showing pictures of like what they have, their charting, it makes it a little easier for them to understand that, yeah, their insurance probably isn't going to cover everything and you might have a little copay. It is a little more work. We're treating you differently. So that's kind of it. And I also tell them that sometimes they don't have a copay. It really just depends on your plan, honestly. Other than that, I really don't get a lot of kickback. Most people that I tell them they have gingivitis, they're like, oh, yeah, that makes sense. And if I mention their insurance, they're like, okay, yeah, that makes sense. I get it. It's kind of my fault, which I don't deny it's their fault, but sometimes it's multifactorial most of the time. I used to never use the gingivitis code because I was scared of what patients would say when I brought up insurance. And I know I technically don't have to talk about insurance because that is not my job as a provider. However, I do think there are some stipulations to that. I think just being a kind human, doing more than you need to goes a long way. If I just put down that someone needs gingivitis scaling and didn't tell them that they might have a copay, and then they get this bill and they're like, what is this for? They don't understand codes. They don't understand that. They just see money, right? If I can prep them mentally and tell them, hey, you have gingivitis, you might have a copay. I just don't want you to freak out if you see a bill because you're going to know what it's for. They see the bill. They don't call and complain. They go, oh yeah, my hygienist told me that this might happen. And then they can call their insurance and kind of dispute it that way. But they don't have to call me because they already know I told them they have gingivitis. I can pull up the note. It says it on there, right? So that does help quite a bit. I would highly recommend if you have a second, even just like if you have to sit up your patient and just talk to them really quick, Worth it. I've done that before. Totally. When it comes to scaling and root planing, I used to work for an office that really liked same day scaling and root planing. We would get some sort of monetary bonus for doing that. So it encouraged us to do it. But after I left, I realized that I really hate same day scaling root planing unless I have like a 2-hour block and I am totally free, or like at least an hour and a half, something like that. Without the adequate time to educate and prepare the patient mentally and go over their treatment plan, etc., it really just isn't worth it, because I would hate to be that patient to be like, oh, you have one quadrant of scaling root planing we need to do, and then we're going to do it today. And then the patient's sitting there like, what does that even mean? Like, I don't even know. And then it's done within the hour. Like, I get some cases that can work, but the times that I did it, it was just so stressful. I just hated it so much. And I don't even think that's ethically correct. I think it's good to like let the patient think about it and process it, at least for most cases. I think there's some exceptions with like maybe a filling or something like that. Bigger procedures, which I would consider scaling root planing a bigger procedure, I think it's good to let the patient brew on it and sit a little bit, I would hate to be rushed into something like that as a patient. And then we get into the area of over-diagnosing and under-diagnosing. When it comes to telling patients they have periodontal disease, most new grads that I know, and myself personally, were terrified to tell patients that they had that because you just feel bad for them, And it took me quite a while to realize that I'm not doing this to you. I am not doing this to this patient. I am simply a messenger from their mouth. I am telling them what's going on in their mouth. They get to decide what they want to do with it. At the end of the day, you cannot care more than the patient does. I have to catch myself doing that a lot because I am so empathetic, and I always try, even in real life situations, to look at something from the other perspective. Why would this person get upset with me? Why is this person upset in general? Why are they sad? Could they be mad at me if I tell them this information? Could they write a bad review of this office? I try to rationalize it before, and sometimes that can get you in a lot of trouble because you overthink and overanalyze a situation that is very simple, to where, yeah, it's gonna kind of suck being told this news, but you know what? I would rather be the hygienist that breaks your heart and you get sad that you have a gum disease than not tell you and you find it out from someone else and you look back and go, holy cow, I've had this for years and no one did anything about it. Oh my gosh, my last hygienist told me that everything was fine for 5 years. Clearly, everything was not fine. And then you have the risk of getting sued for like neglect and stuff. What's the point in that? Just keeping someone happy, but then they get disappointed anyway? Literally, where's the fun in that? Just break their heart once, tell them the bad news while it's early. It's easier doing 1 quadrant or 2 quadrants of just a 5mm pocket anyway than waiting down the line until it's so grossly neglected that they have to go to the periodontist. Like, why do people do that? I have no idea. I think people in dental hygiene do get lazy. I have seen some lazy hygienists out there, and it's no shade. It's just facts. I've cleaned up after many hygienists, and I will happily do it because I'm getting paid to do it. I love educating patients, but it is exhausting. It gets exhausting telling hundreds of patients that they were mistreated. And I don't say it like that. I just explain to them what's going on and answer any questions. And sometimes that comes up, and I'll be honest with them that like, hey, I don't know what the last hygienist was doing. I wasn't there, but I'm telling you what I'm seeing now. And it looks like this has been going on for a while, but I'm glad we're catching it today. Going back to my statement earlier, if you tell patients bad news, but you can flip it into maybe something positive, it just, instead of going down, 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 it's a little bit up at the end, and it can really help long term. Wow, so good. So good. If I can leave you with any advice, I would say if you're in hygiene school, ask a million questions. Do some case studies with your professors. Ask all sorts of different professors what they think about different cases. Get more opinions. If you're a new grad, talk to the hygienists and the doctors around you. Do case studies with them. It kind of goes the same way. The more you know, the more better you can do. And then if you struggle with diagnosing and coding and everything, honestly, just pull out the ADA book, do some research online. That's what's helped me the most. Even just watch TikTok videos about it. I think there's quite a few out there that are really helpful. Well, I'm going to wrap up this episode now. I hope you enjoyed it. I really had a fun time talking about this subject because it takes a lot of time to become confident in something. If you get out of school and you just know that you're going to struggle with it, it's a scary feeling. And there's some mean people out there that will kind of push you down. And there's no point in giving up and just being like, well, I just can't do this. Like, no. If you can put yourself out there, study, ask questions, educate yourself, periodontal diagnosis and gingivitis diagnosis is going to be so much easier and so much quicker. That's the best part. You can probably catch me diagnosing perio in 3 minutes if I have everything I need, And that's how it should be. It should be concise, and you should be able to articulate what's going on to a patient in the matter of 15 minutes, in my opinion. Sometimes it can take you longer, and that's okay, but try to get to a point where you're very efficient to where it's not burdening yourself and you're not maybe scaring the patient by talking too much or anything like that. I don't want to discourage talking at all. I just think that keeping it short and sweet and just to the point really saves you some heartache and saves the patient some struggle too. I think sometimes patients get stressed out just hearing a lot of things at one time, and I totally empathize with that. Some patients like it, but most patients don't. Practice. I think if I can say anything at the end of this, polished is not perfection, it's progress. Anyways, I hope you have a great day, and I'll see you in the next one.